Mr. Suleiman.
Madam Chairwoman, Ranking Member, distinguished members of the Subcommittee, on behalf of more than 200,000 members and supporters of Iraq and Afghanistan Veterans of America, I thank you for the opportunity to share the views of our members on these very important pieces of legislation. My name is Ramsey Suleiman, and I am a legislative associate with IAVA. I'm a veteran of Iraq, where I was an infantry platoon commander and company executive officer. I've spent 14 years in the Marine Corps trying to execute the Marine Corps' two missions, winning battles and making Marines. As an IAVA staff member, I don't make soldiers, sailors, airmen, or Marines, but I do try to make their lives better. The views expressed here are not the viewpoints of the Marine Corps. They are solely mine and IAVA's analysis. Thank you for your attention to the pressing issues facing our nation's veterans. IAVA strongly supports H.R. 1460, ensuring that veterans are automatically enrolled in the VA healthcare system and required to opt out if they do not wish to be enrolled. Actually getting veterans into the VA system is the most important part of a smooth and seamless transition from the Department of Defense healthcare system to the Veterans Administration healthcare system. Currently, only 54% of Iraq and Afghanistan veterans are enrolled in the VA healthcare system. The steep cost of quality healthcare through the private sector and a high rate of veteran unemployment, almost 17% among our membership, means many veterans do not have access to any other healthcare system, often for their service-related injuries. IAVA believes that H.R. 1460's solution, changing enrollment, is an easy and effective both in terms of cost and efficacy. Combat veterans should not have to opt in to receive a benefit they have earned through their service. We also support H.R. 3337, the Open Burn Pit Registry Act of 2011. Burn pits have the potential to be the insidious and long-term health issue for our generation of veterans that Agent Orange has been for Vietnam-era veterans. H.R. 3337 gets ahead of the curve in responding to potential future health concerns by establishing facts. Who was exposed, where were they exposed, and for how long? These small but crucial pieces of information will be helpful in the future in ascertaining the health impacts, facilitating subject identification for epidemiological studies, and adjudicating claims. Burn pits were ubiquitous in Iraq and still are in Afghanistan. They are located in the midst of large numbers of troops. The twin facts that burn pits are the way waste is disposed and must be co-located with troops for logistical purposes guarantees exposure for most veterans. While IAVA supports H.R. 3337, we do so with a caveat. Because of the ubiquity of burn pits in these conflicts, we believe that the definition of burn pit must extend beyond solely those authorized by the Secretary of Defense to include those that were established by small unit commanders to facilitate mission accomplishment. In other words, there is no garbage service for our troops to rely on in Iraq and Afghanistan, and by necessity, we burn all the waste that we have. This is a necessary addition to this important piece of legislation, and IAVA encourages inclusion of such language in the bill before passage. We also support the goals of H.R. 3723. We believe they're laudable and we support many of them. However, we cannot support H.R. 3723 because we believe that this legislation makes several changes that are untested and do not necessarily provide hope of significantly improved patient outcomes or access to care. There are significant issues in the VA healthcare system, and my colleagues in the other VSOs have addressed them at length. I would just say that we reiterate most of those, and we think that there are many questions that need to be answered before such a drastic step is taken. We would also point out that there are many medical options that are not cost-effective in the private sector, such as prosthetics, and real questions exist regarding the fiscal benefits and patient outcomes when outsourcing these types of care. The bill begs the question of whether another system that makes the VA a third-party payer, essentially replicating the scenario encountered with fee care, or should the VA system be strengthened, funded, and fixed that the use of third-party non-VA providers is minimized and truly used out of necessity. IAVA prefers the latter option, and therefore we cannot endorse 3723. In the interest of time, I've submitted all my other comments for the record, and I look forward to answering any questions that the committee has. Thank you very much.
Thank you. Thank you.